Welcome to our world. This is your global.
But I started getting interested in genetically transmitted disorders when I was in training. In the part of India where I was getting trained, we used to have a lot of hemolytic jaundice because of a particular gene called G6PD, or glucose 6-phosphate dehydrogenase. And the funny part was that, we used to have these high bilirubin levels, but maybe 30% or more were females. And I didn't understand as to why. And nobody was asking that question. I was told that maybe, obviously, if both the X chromosomes are defective or have a mutation, then this can be explained. But this was an exceedingly high frequency. The second thing was that when I looked at the frequency of, say, congenital anomalies, such as, in Beckwith-Wiedemann, because there's a lot of diabetes all around, or, say, Silver-Russell syndrome, the incidence of the so-called epigenetic or disorders mediated by epigenetic mechanisms is far more. Like when you're looking at a genetic disorder, there is a lot of heterogeneity, but maybe 5, 6, 7%, and correct me, Pankaj, if I'm wrong, but the epigenetic disorders are far more frequent. So that's why I started becoming interested in epigenetic mechanisms. Because the same infants who I sent back with a list of drugs not to be, not to receive if they are G6PD deficient, when I saw them like 5 years later or 6 years later, and I said, hey, did you follow that list I had given you? And they said, doctor, when I received that list, and when the child was 5 years old, he received those drugs, and I was very, very much afraid that he received those, or she received those drugs, but nothing happened. So something changed in life. And so that's when I started thinking about epigenetics. Now again, I welcome you all to this inaugural meeting of the Global Newborn Society. I have received a lot of positive feedback. This is the inaugural meeting, so we hope we'll grow. And this is something, I think this will make a change. We are in an era where we are thinking of personalized medicine. And there is no rocket science in this. You go to buy clothing, and my size doesn't fit yours. So how is it possible that I prescribe you 100 milligrams twice a day, and you will be expected to be fine just as I would be? Doesn't make sense. So if you look at personalized medicine, it's a medical model which emphasizes an individual's genetic profile in the agent-host-environment triangle to tailor disease prevention and treatment strategies, because you are not the same as I am. Instead of a one-size-fits-all approach, it aims to match the right therapy to the right patient at the right time, because times may be different, right? Because as we had heard in one of the earlier talks, that the environment, the toxins, make a difference. And this will lead, hopefully, to customized medical decisions, practices, and products. The key aspects of personalized medicine, one is obviously you need genetic and molecular information. Individual genetic makeup such as next generation sequencing. We just heard a brilliant talk by Pankaj to understand the unique risk for certain diseases or the likely response to specific drugs. No questions asked. Absolutely. Established right there. The trouble is the frequency, the relative frequency as to if this was so frequent, then why would I get away in 96% with the same thing or suffer in 50 or 60% of conditions? And these reverse with time, and that's a problem. So we need a tailored treatment. Select the most effective medication, drug dosage, or therapy for a patient, potentially reducing side effects, improving outcomes. And the best examples are in cancer care. Pharmacogenomics. So like in a lot of countries in the peri-equatorial tropical belt, there is a fixed prescription, but nobody is measuring blood levels of certain drugs. And we all know we have different capacities to remove the amount of drug that has been prescribed. Maybe it is the glomerular filtration rate or the ability to excrete those drugs in the colon. Then we obviously need a holistic approach. There is no doubt about it. The agent host is a part of it, but it's likely to be an octagon or a nonagon. The question is about personalized medicine. Do you know that only 2 to 4% of all genes are actually translated into proteins? 10% are the carrier proteins. And the remaining 86% are silent. We don't even know what these genes are doing. And I'll come to this from a personal experience. So what happened was, maybe about 10 years back, I developed, and this is a full disclosure, I developed a form of cancer. I was most likely going to die. I had a 35-36% chance of survival. And then they found that I have the deficiency of a specific protein. It activates the cytotoxic T lymphocytes against that gene. They took the CTLs out, they washed it. And so this protein, whatever was defective, it got removed from the surface of the cytotoxic T lymphocytes. These cells increased from 1500 or 1600 per 100 ml to 20 million. And they gave me 10 million and 10 million. And here I am, running up the stairs, talking with you, thinking, and whatnot. So this is something where epigenetics comes in. In neonatology, this is something even more important. And I think, as we talked about, and Pankaj and I often argue about it. I mean, I respect him a lot, but I say, Pankaj, whatever you're doing doesn't make sense. And Pankaj says, Akhil, you think too much. This doesn't make sense. So this is something really, really important. That the modifications on proteins, which are there in the first 5 or 6 years of age after birth, this is something which is potentially very important. Like we heard this talk about the environmental toxins. We do not even know if these changes are lifelong. This is a horrible slide, really, crowded. Let me see if I can. I cannot. So this is a cell, just bear with me, and if you look at this, these are the chromosomes, and this is in progressively increasing magnification. And when you eventually go to where you need to go, there is DNA wrapped around a protein core, which is composed of 5 different kind of histones. These are proteins. And that's where chemical modifications of the DNA, which is called methylation, or there could be chemical modifications, which are of 10 types, of the central histone core, which will make a difference. And I'll show it to you in the subsequent slides. These are the epigenetic modifications. When Pankaj said he is going to talk about genetics, and he said, Akhil, what are you going to talk about? I said epigenetic. So this was a joke, but this was something which was turning out to be important. We've all heard about DNA methylation. It is there at birth, might go away or might not go away. You might have subsequent generations which might be carrying genetic DNA methylation. Then there are RNAs, which, and I'll bring this in more detail. We have heard about small interfering RNAs, microRNAs. Then there are post-translational modifications of histones. And I think this is where the treasure for us neonatologists lies. There are 10 different types of chemical modifications on histones. And that is where we want to focus on. So let me take a little break, and the Global Newborn Society is starting 2 projects. One is we are going to develop a diploma in medical genomics. Genomics word is because we are going to do sequencing. But the second part is we are also going to look at epigenetics. The costs can be significantly reduced. This was a question which came up. But thanks to Zoom, we can, if we decide on what we want to hear about, then we can make a syllabus, and then we can have experts from all over the world, and Pankaj volunteered. So we will have this diploma, which is needed, because if I as a neonatologist go to a genetics department and say, sir, I need to do a sort of an advanced qualification, like what would you call it, Pankaj? Sorry, my ATP is all gone. Like a fellowship in genetics, they would say, sir, you have to go and do a residency in genetics first. So there are certain barriers in neonatologists becoming geneticists. That is the problem of the system. However, in NICU, in the neonatal ICU, this is everywhere. And this is not in the NICU alone. When you see patients in the clinic, there is this problem everywhere. Now the problem is, the bigger problem is that you can diagnose Down syndrome. I can diagnose Down syndrome. We say 95% are classical Down syndrome. 4% are, where the chromosome is altered. So that is that kind. And 1% are mosaics. Do you think it's right? I don't. I think it's very likely that a larger number of cells are mosaics. That it's very likely that those cells some cells have trisomy, some cells do not. So that's why you have siblings where one has all the manifestations of Down syndrome, and the other child looks a little bit like Down syndrome, but does not have the same problems. This child might not be doing so well in school, maybe has some manifestations, but does not have all. And the point is that if you look at the differences in different siblings, like, if one child has Down syndrome, you look at all the clinical manifestations. You can say this child has 95% of all the symptoms that I see in one child. This child has 30%. Why? Because it is very likely that you're dealing with a mosaic. Then I'll come back to the 10. One is, these are the epigenetic modifications. As we are looking harder, we are finding more and more of these chemical modifications. So you can have ubiquitination. This is a small, ubiquitin-like modifier. It's called small ubiquitin-like modification, or sumo, like the big wrestler, but it is not quite as big. Then you're looking at glycosylation, hydroxylation, phosphorylation, sulfation, acetylation, citrullination, crotonylation, malonylation, ADP ricylation. I'm not going through this list to impress you. I'm going through this list to tell you, or to tell myself, that how extensive are these epigenetic mutations. Isn't this list telling me or you that these changes are more likely than the small single mutation, which is an accident of nature, as compared to these 10 changes? The game of probability is completely different. Then you have prions, that your genetics might be altered by prions, but it might not be manifesting all the time. You have chromatin remodeling. Why does, if you have a prionation or you have, post-translational modification, wouldn't the three-dimensional structure change? And then its interaction in 3 dimensions with another gene on another chromosome change. Then you have nucleosome positioning, same story. Then sex-specific epigenetic changes. So you have genomic imprinting and chromosome inactivation. So what I'm saying is the story might be too complicated. So coming back to my own story, here I'm talking as a physician patient. So what happened was I developed this kind of cancer. And then I underwent every possible treatment. Chemotherapy, surgery, radiotherapy, autogenic bone marrow transplant, immunotherapy, more chemotherapy. And they said, Akhil, you need to have an allogenic bone marrow transplant. I said, that sounds good. I found 9 potential donors in my family. And I said, yeah, I'll go for it. Then suddenly something changed. And I asked, what are my chances? And they said, Akhil, we're the best in the world. So I said, that doesn't sound good to me. What are my chances? So they said 35%. I said, okay, that sounds very good. I'm in good health. So, but what if this fails? What are my chances? And they said, unfortunately, if this fails, you don't have anything else. So I said, I'm sorry, I'm not taking it. And they said, you're making a mistake. And I said, I'm sorry. So at that point, something changed. I got an invitation from NIH, and they said, we are looking for 5 genes, and you're welcome to be tested. And the funny part is, as I said, 4 to 6% genes in our body make proteins. 10% genes are transfer proteins, the tRNA. And then 86% genes are not expressed. And it turned out that the gene was wrong in my body was an unexpressed gene. And when they found that gene, then they looked for CTLs, the cytotoxic T lymphocytes, and they washed those, and I got cured. Now I got cured. And I've been, again, I'm sharing all the details because I think it's so important as a clinician. So I was a very careless student. I was good, but careless. Like I could leave my room unlocked. And somebody called me and they say, hey, you forgot to lock your room. And I would say that, hey, enter my room. There is a table on the right corner, which is near the window. There is a bunch of papers sitting there. You lift up the papers and there is my key. You take the key, lock my room, and keep the key with yourself. I'll take it in the evening. And then gradually, I started forgetting things. And people said, oh, it is an effect of age, don't worry, we're all like this. You start noting things down and you'll be fine. But then that didn't, I wasn't satisfied with that answer. So what happened was that I was reading about it, and my mother had a multi-infarct dementia before she passed away. And these were, in her MRI, we found multiple microinfarcts everywhere. So she had dementia for 2 years before she passed away. So I thought I should undergo a workup for hypercoagulability. And the hypercoagulation workup typically includes 5 genes: factor V Leiden, protein C, protein S, homocysteine and others, right? I mean, the usual ones. But the funny thing was, I thought it is not complete. So I said, I want a full workup. And that one of those genes is called methylene tetrahydroxyfolate. Yes. So there is a difference between folic acid and folate. What we eat is folate. Folic acid is a drug which we use for preventing spina bifida. So in our body, folate gets converted to 5,10 methylene tetrahydroxyfolate. And then that gets converted by this enzyme MTFHR into 5-methyl tetrahydrofolate. Okay. It turns out that when I asked for a full hypercoagulation workup, I am a double heterozygote for MTFHR. So, okay. I go to a store and I find this drug which is being sold as a supervitamin. Okay. I buy it, and then I looked up at the literature and I asked what is the right dose, and there is no dose. I did an extensive research in PubMed. The prescribed dose is, say, 500 to 5 milligrams or 7 milligrams of this twice a day. Then I looked up at the literature, and people have given up to 38 milligrams twice a day. Why? They say it's water soluble. If you take too much, you will pass it out in urine. And I asked the question, what if I take too much? Will it bother me? And the answer is no. So I took it, and suddenly it's like I'm wearing a new pair of spectacles. My memory has changed. So again, an epigenetic change. MTFHR is not deleted in me. Right? I'm a double heterozygote, but I'll give an example. My nephew, he had you measure the activity of MTFHR by measuring homocysteine levels. His homocysteine level was 9, and his one of the 2 genes shows a mutation. Right? And then he started taking this medicine, and it dropped below 2, and his thinking has changed completely. So this is where we need to think. And this is important for us neonatologists, because many of these changes are very transient. But the frequency is far higher than any of the syndromatic diagnoses. When we look at epigenetic mechanisms, there are a lot, and this is where I think the treasure is. So one is microRNAs. MicroRNA is a 20 to 24 nucleotide long, produced in the nucleus, and is capped and polyadenylated single-strand RNA, and it's an imperfectly paired stem loop structure. But we have good methods to measure and detect microRNAs. Processes by 2 enzymes, not important, you can overlook it. Perfect complementarity. There are mechanisms which are known, but at clinicians, I don't know if this level of detail is needed. Transcriptional silencing and translational activation are the mechanisms, minor functions in silencing and activation. Then they're called picoRNAs. It's a long name. It comes from PIWI, interacting RNAs. These are precursor single-stranded RNA modified to contain, again, minor chemical modifications, strong preference to a particular base at the 5' end, and it causes silencing on transposable elements in the germline. Long story short, it can cause a transient change in your genome expression. Then siRNAs, small interfering RNAs, again, simple mechanism. It can cause transient or transgenerational change. This is something to be measured. Then there are long non-coding RNAs. These are, they can be up to 200 base long. Many of these are subject to splicing and other changes. They can cause chromatin remodeling, transcriptional regulation, and also mediate post-transcriptional regulation. I'm not getting into a lot of detail because as clinicians, this is important, and we need to look at these things so that we build facilities to detect those. And we need to think about those as clinicians. This is a component of nuclear organelles. Again, these are speckles. If you stay in the nucleus, you'll see those, but not important for you or I. There are enhancer RNAs, again short half-life. These are small sequences found in the nucleus which can change gene expression. Then again there are promoter-associated RNAs. These can also alter expressions. The reason why I'm going through all this is that to give an idea of the number of mechanisms we have which goes beyond genetic mutation. This is a chemical change on histones, which are the DNA-associated proteins. And this is one example where the best studied change is methylation, and this is where methylation occurs. This is a more complex figure. A nucleosome is a basic unit of a DNA packaging. A packaged DNA in eukaryotes consisting of a segment of DNA which is wound around a core of 8 histone proteins. Okay. Actually, it's 9 because H1 histone is a little bit separate and we do not know the complete function of H1 histone. But it's not important for you or I when we look at it in a therapeutic sense. And again, it shows some of the mechanisms. We can go into the detail at the end if we need it. Where do we go from there? The interesting part is that a number of drugs are now coming into shape. And these block histone acetylation. And this is why I am becoming progressively more interested in epigenetics. Because this is something we can block. If you have a genetic mutation, you're done. How do you change something that is a disorder? Maybe you can replace it. But then, where I went through, then you have to adjust the dose. If you have an epigenetic change, the mechanism to reverse it in a therapeutic sense might be much easier. And as a neonatologist, maybe we all need to know much better, much more in depth about these things because this will change life. And there are these lists. I'm not going into the detail. So it's important to remember that every baby counts. And in babies, these epigenetic changes, for some reason, are much more important. By the age of 4, 5, or 6, these changes reverse. So I'm saying that this is the reason I'm showing all these feet, because I don't have a problem of identification. I don't have to cover those eyes. But this is something which needs to be studied in every region of the world. What is true in the United States might not be true in other parts of the world. And this is where the exposure to toxins, Rachna is in a different room, I think that is so important. In many parts of the tropical peri-equatorial regions, the exposure to pollutants is so high that these changes might be far more important. We are not living, all of us are not living in Scandinavia where the environment is so clean. So this is where I'll end. Thank you so much for your time. And we can talk about this in far more detail. This is what I read day in and out. Thank you.